Thank you so much for that really warm introduction. I am so excited that Dr. Brown's Medical invited me to come share this presentation with you all today. The reason that they reached out to me was because of a research study that I've been working on over the last couple years, which looks at some of the early feeding and developmental outcomes of infants who have undergone therapeutic hypothermia. I'm so excited to share these results with you today, as well as some of the latest research on the outcome of these babies. So my presentation is entitled Improving Outcomes for Infants with HIE, Latest Research to Guide Neonatal Clinicians. But before we get started, I do need to share with you, for disclosure purposes, that I am receiving an honorarium from Dr. Brown's Medical, as well as am a consultant for Lancino Laboratories Incorporated, although we'll not be discussing their products today. Finally, I do practice at a large teaching hospital in the Bay Area, but all opinions I express today are my own and do not reflect the place where I work. I have no non-financial disclosures. So by the end of today's presentation, you will be able to list 2 specific feeding difficulties, which are commonly noted in neonates with HIE, describe 2 developmental patterns initially noted in neonates with HIE that often improve by discharge, and finally understand 3 therapeutic interventions to support improved developmental and feeding outcomes in neonates with HIE. I know many of you in attendance today probably already have a good understanding of what hypoxic-ischemic encephalopathy is, but I think it's really helpful to break down a really long word by looking at the definition of each part. So hypoxic means a shortage of oxygen, ischemic means a shortage of blood, and encephalopathy is the resultant brain damage. So HIE, in short, is a shortage of oxygen and blood, which contributes to brain damage. With the diagnosis of HIE comes a persistently abnormal neurologic exam, which is why we are so concerned about this finding in our neonates. This abnormal neurologic exam can include things such as an altered level of consciousness, abnormal tone or reflexes, altered respirations. Additional signs on the physiologic level include low APGAR score, low cord pH, and neonatal seizures. The SARNAT staging of encephalopathy helps us to determine what level of severity the HIE has. So there's mild, moderate, and severe. This is usually something the physicians are recording, and it looks at the baby's level of consciousness, spontaneous activity, posture, tone, primitive reflexes like sucking and moro, and also the baby's autonomic system. There are many different reasons why HIE can happen, including perinatal asphyxia, stroke, infection, metabolic disorders, and congenital brain anomalies. And something that is interesting is that often the etiology of the HIE is not known initially. All that's seen is the persistently abnormal neurologic exam, and the underlying reason for the HIE comes to light in the coming days, weeks, sometimes even years. The incidence in the US is about 1.5 per 1,000 births, which ends up being about 12,000 births per year in the US. For these patients, therapeutic hypothermia is the proven treatment strategy to reduce acute brain injury. So for therapeutic hypothermia, the babies receive whole body cooling, which helps to slow the spread of cell injury and minimizes permanent damage. So it really helps these babies twofold: to reduce the acute injury, first of all, and then second of all, slow down or diminish the secondary injury from the initial insult. So for 72 hours, the infant is cooled to approximately 32 to 34 degrees and then very slowly and carefully rewarmed. This happens while watching the baby's vitals and making sure the baby is really stable from a physiologic perspective. Each center that provides cooling has very specific guidelines to ensure that only babies who need it are the ones receiving this care. And these guidelines are based on the gestational age, which is usually 36 weeks or older, The baby must be very recently born, so less than 6 hours is the age by which cooling needs to start. Of course, there needs to be moderate or severe encephalopathy. Babies with mild encephalopathy are generally not cooled. And also there needs to be evidence of hypoxia. So for facilities that do not offer cooling, a lot of neonatal transport teams are able to initiate cooling, which is a fantastic service that can be provided. So these transport teams can go to hospitals that do not have the capability to cool infants themselves, but start the cooling process and keep the baby cooled while they are transported back to the center where they will receive the long-term care. So I heard someone once say that surfactant was to the 80s what therapeutic hypothermia has been to the 2000s. And I think that that really speaks of the power and improved outcomes that we have seen with the implementation of therapeutic hypothermia. So the paper that I've referenced on this slide is a really fantastic and relatively short read for a comparison of outcomes prior to the invention of therapeutic hypothermia and afterwards. It summarized several different studies, only a few of which I've included on this slide for us to talk about. So for instance, the first study on this slide looked at death and also rates of moderate to severe disability. And before the implementation of therapeutic hypothermia, the rates of death or moderate to severe disability were 62%. After the implementation of therapeutic hypothermia, these rates dropped to 44%, which is incredibly dramatic. Another study that looked at mortality rate found the rate to be 37% for patients prior to therapeutic hypothermia, and it dropped to 24% after therapeutic hypothermia had been implemented. And finally, there was another study referenced in this paper that looked at moderate to severe cerebral palsy. And prior to therapeutic hypothermia, the rate was 30%, but it dropped to 19% once therapeutic hypothermia was an proven treatment strategy. So as you can see, there really is quite a few benefits and obviously really strong research to support this as the current primary treatment for babies with hypoxic-ischemic encephalopathy. So over the years, as I have begun to treat more and more infants who have received therapeutic hypothermia for HIE, many questions and ideas have started to formulate in my mind. What are the early feeding patterns? Are there early feeding patterns that exist? And what do these specific feeding patterns and behaviors mean? Are there signs that indicate future feeding potential? And on an even bigger scale, can we use some of these early feeding and developmental findings to prognosticate outcomes? So in addition to these questions, I started to notice some patterns. So very consistently with these babies, there seemed to be issues with state control. And so what I mean by that is the baby may have had a reputation from being a baby that goes from 0 to 60. And what that means is it's a baby who has a really hard time transitioning from being asleep to a quiet alert state, and maybe even skips the quiet alert state. So these are the babies that have kind of two states, either sleeping or crying, and don't really have that in-between quiet alert state, which we know is so important because that's when babies learn. That's how babies best feed. That's how they interact with their environment. Additionally, I noticed many of these babies had very jittery movements, as well as issues with tone, whether it was hypertonicity or hypotonicity. And a lot of times that tone fluctuated and changed from the initial evaluation till the time the baby went home. And with feeding, one of the main things that I noticed that was really different with this patient population than other patient populations I've treated is a difficulty with establishing latch. And so what I mean by that is the baby was rooting and really interested to feed with strong cues, but when the breast or the bottle or even the pacifier was placed in the baby's mouth, the baby continued to root and continued to look for the stimulus, even though it was there. Additionally, with this patient population, I saw a lot of coughing and choking with initial feedings. And so many of you on this call probably already know that typically when neonates aspirate, it's silent. So there's not an outward sign of the difficulty that they're having. So seeing this many babies with coughing and choking at their initial evaluation with me was highly concerning, that there was something bigger underlying their feeding issues. A lot of times it got better by the time they went home, but what are we supposed to do with this early coughing and choking? How do we address it, and how concerned should we be? Another common issue that I identified as a barrier to progression of feeding was disengagement. So abrupt disengagement, which is a red flag when you have a baby that's giving strong cues and really engaged and interested in feeding. So with all these thoughts moving around in my brain, I decided to take some action and meet with the research team at the hospital to share my ideas and brainstorm about what kind of research study we could do. So that led to the retrospective research project that has taken up much of my time over the last couple years that I'm sharing with you all today. And I also had the opportunity to share a research poster at the National Association of Neonatal Therapists this past April in Phoenix. So what we did was sort through our database of neuro-NICU patients and started with 137 patients. We excluded patients who were not cooled, as well as patients who passed away, which unfortunately there were some of those. And we also removed patients that were in our former electronic medical record because we were worried there could be some confounding information or difficulty getting the same information between the two different EMRs. So that left us with 72 patients who received therapeutic hypothermia for moderate to severe HIE. So the study spanned from the dates 2013 to 2017. That was where we collected the retrospective data from. And we began collecting information, so data from the OT and PT evaluations, and then information on the developmental progress and outcomes, as well as the feeding progress and outcomes. So here are the demographics from the cohort of neonates in our study. And as you can see, the gestational age average was 39 weeks, so these were full-term babies. The birth weight was just over 3 kilograms, so again, very average for a newborn baby. The post-menstrual age at discharge was around 41 weeks, which means the length of stay was somewhere around 12 to 14 days. You can see with the length of stay, there's a really large standard deviation because there was quite some variability in length of stay, depending on how acutely ill or involved the patient's medical care was. So beyond the demographic information, we also collected very detailed information about the feeding and nutrition. So that included TPN use, IV fluids, enteral feedings, oral feedings, and also the progression and transition off of TPN and IV fluids to full enteral feedings, and then often to full oral feedings as well. We also collected information on the timing, frequency of OT and PT evaluations, as well as discharge recommendations from a therapy perspective. But the thing that interested me the most was what were the actual findings and patterns in the OT and PT evaluations as compared to the discharge sessions. So in looking through the therapy notes, we identified 5 specific areas that we collected information on. So coughing and choking, if the baby had that documented in either the evaluation or the discharge summary. Upper airway congestion with feeding, so that wet, gurgly breath sound that wasn't there before the feeding started. Difficulty with latch, which again is that baby that's doing the hyperactive rooting response where they just can't break out of the cycle of kicking into the rooting reflex. Issues with state control, and then any issue with tone, whether it was hyper or hypotonicity. So the preliminary findings from the therapy initial evaluations of those 5 markers identified many problems and patterns to the baby's behavior. So about 2/3 had state control difficulties. So before we gathered this information, I knew that state control difficulties were very prevalent, but even I was a little surprised that 2/3 of babies had this identified as an issue. Abnormal tone, so either hyper or hypotonicity, was noted about 80% of the time. 1/3 of the babies had coughing and choking or upper airway congestion. So those are very concerning signs for potential underlying aspiration. And again, that was noted 1/3 of the time on the initial evaluation. And pretty dramatically, almost 2/3 of the babies had difficulties with initial latch. Again, those babies that root and root and root and cannot find the stimulus in their mouth. So as you can see, there were a lot of issues that were identified early on. So what can we actually do to help these babies when we see these issues? So first things first, parent engagement and involvement is incredibly important. So Biscoff did a study on infants with HIE, and he looked at parent involvement with diapering, holding, even supporting tube feedings. And what he found was not necessarily a surprise, but I still think incredibly significant, which was that parent involvement increased when the parents could be in close proximity to the babies. And what that means is families who are allowed to either room in the hospital or have accommodations or lodgings very close to the hospital. So this is really important to keep in mind because a lot of babies who are cooled at these larger hospital centers come from small regional hospitals. So there can be a lag in parent involvement just because of the geographic difficulties. So anything we can do to advocate to have the parents involved early and located closer to the baby is incredibly important. Another thing we can do is encourage early holding while the baby is being cooled. There are many facilities that are already doing this, but there's a lot of emerging research around this area, making sure that there's no temperature fluctuations for the baby while being cooled, the vitals are stable, and the baby is tolerating it well. And then of course, once the baby is rewarmed, that's when skin to skin and early breastfeeding can begin. And these are babies who particularly need it. It is so soothing and improves their state regulation when they can be skin to skin or practice with breastfeeding as early as is safe for them to do so. Some things to avoid with this patient population is overstimulation. Now, I know that none of us have perfect control over a NICU environment. It could be you work in a facility with single family rooms, or you might work in a NICU where there's still a bunch of beds and a pod. And so we don't have complete control over the environment. But something we can do is teach parents how to approach the baby in a therapeutic manner with a quiet voice. We can put screens up or things to give the parents some privacy and slow down kind of the pace of the environment around the baby, because avoiding this overstimulation is really, really important, especially with feedings. And then finally, we want to support the baby's ability to self-soothe. And that might mean giving them something to suck on, whether it's a gloved finger or mom and dad's well-washed finger, a pacifier, and also helping the baby from a positional standpoint. So providing supportive containment or a swaddle when it is safe for a baby to have that. So the benefits offered from skin to skin are especially important to infants who have a period of separation from their families. And with all babies who are cooled, there is a time period where they cannot be held skin to skin as they cannot have their body temperature warmed up. But when the baby is physiologically stable and ready for skin to skin, being skin to skin can actually improve their physiologic and respiratory stability. Skin to skin also supports brain maturation and growth, which obviously is very important for this patient population. Skin to skin can help to decrease the risk of infection, as well as decrease parental stress and pain while improving infant and parental bonding. So although these babies are not born preterm, it's incredibly important to remember that this is something very valuable for them to do with their families. So another powerful developmental support for these babies is positioning, such as swaddling. This helps to bring the baby into physiologic flexion and maintain midline orientation. And it helps the baby to organize and access their environment. So a lot of times we think of the importance of swaddling for our preterm infants, but really for our babies with neurologic sensitivities, this is incredibly important to give them support to make them calm and feel organized from a neurologic perspective. There are so many studies of the benefits of swaddling for preterm infants that show a decrease in pain and stress cues, but I do want to highlight a recent study, and this was by an OT out of California. Her name is Allison Smith, and she looked at babies born at less than 34 weeks and used the infants as their own controls. And what that means is she had the babies feed unswaddled and then feed swaddled, as well as vice versa, to see the difference of feeding swaddled versus unswaddled. And many of us know intuitively through our practice that this is something very valuable to help a baby organize and do a good job with feeding. But she actually did measurements using the early feeding skills assessment and found that the babies, when swaddled, showed significant improvements in all areas with the early feeding skills assessment. The only area that did not change was the marker of oral feeding readiness, which obviously that's not related to the swaddle, so that makes sense. For our healthy term infants, the study by Franco showed that infants were able to sleep longer, awake less spontaneously, and also spend more time in non-rapid eye movement sleep. And this is so important because we know that non-REM sleep is when brain growth and development happens. So it's incredibly important for our neurologically fragile babies. So another powerful developmental support for patients with any kind of neurologic compromise is massage. So this was a study out of China a few years ago that looked at the effect of massage on neurobehavioral rehabilitation. And 60 babies were enrolled in the study with moderate to severe HIE. Both received all regular hospital and nursing care, but the research group received a whole body massage twice a day for 2 months. Now, that sounds like a lot when we think about caregivers adding that to their role while working in the hospital. But if we think about getting parents to do this, I think it's something that's incredibly doable. So then what happened is the researchers evaluated the baby's neurological assessment at birth, day of life 3, and then at weeks 1, 2, 4, and 8. And what they found was that the research group demonstrated significant improvements in the NB-NA score at all different times. So I find that massage can be a really organizing and beneficial intervention before feeding times. So as opposed to our preterm infants who quickly fatigue or have a small window in which they're able to participate in feeding, a lot of times doing a preparatory activity to help the baby reach a quiet alert state, feel organized and supportive can be incredibly valuable. So this may be something you want to think about in your practice. Does it make sense to have the parents massage the baby beforehand? Is it helpful to have the physical therapist come right before a feeding session? A lot of times I find those are when babies can really do their best, is after they've received that support. So the reason that I've included nutrition as a part of developmental support is that we all know that nutrition is linked so closely to oral feeding success. If babies are not feeding successfully, that obviously tells them we potentially have other developmental concerns for the baby, but also if they are receiving inadequate nutrition, their developmental status can suffer. So this was a study out of South America in 2008 by Davy Bean, and what he did was look at hyperalimentation of neonates who experienced HIE. And so hyperalimentation meant that the research group received 120% of the recommended intake for protein and nutrition. So not just received the typical nutrition per their weight, but received an additional 20% beyond that. And so very quickly, what they did notice was that there was a significant increase in head circumference, as well as a significant increase in axonal diameters in the corticospinal tract. So the study was designed to run for much longer, but was terminated much quicker than they had originally anticipated, because with the very first 16 patients enrolled, they had really dramatic results. And so I find this study really interesting because it's not something I hear referenced a whole lot. And I know it was relatively small scale, but it does make me think, you know, these babies need such well-supported feeding plans, and they're not babies that should go home, you know, just skating by, just taking enough. You know, they need to really have good support, good teaching in place to have a safe feeding plan that maximizes their nutrition. So because we want these babies to get the very best nutrition that they can and do so safely, we need to be doing things to support their feeding. So one of the first things we can do is give the baby a supportive environment in which to feed. Like I've said before, there's a lot of things in the NICU I know we cannot change or have control over, but because these babies are so sensitive and easily overwhelmed, we want to teach the parents and staff as much as we can to provide a quiet, supportive, and nurturing environment to allow the baby to maximize their success. Additionally, we want to offer early oral motor stimulation, and that can be either at the breast or opportunities for practicing with non-nutritive sucking before oral feedings can start. And a lot of times for these babies, non-nutritive sucking, such as with a pacifier or on a finger, is easier than the bottle because the baby just needs to focus the latch on the stimuli. Baby doesn't also have to worry about liquid coming at the same time. And as we've already talked about, swaddling during the feeding will give the baby good neurologic support and help them to be organized to really do their best. So additionally, we want to be very cognizant of the positional support that we're providing the baby during feedings. If it's a baby that is having a hard time managing the flow of liquid, maybe side lying is the right position to try. If the baby really benefits from being upright, which can facilitate a more awake state, maybe that's more appropriate, as long as the baby is well supported and is offered some flow control if needed. Another thing we want to do is teach parents how to facilitate a successful latch. And what I mean by that is these babies sometimes have a really hard time, again, with that hyperactive rooting response. But what I see is the baby moves their mouth quickly to look for something to latch on. Often I see parents moving the bottle or moving the pacifier. So then we have two things moving really fast, and the baby is unable to connect and form a successful latch. So what I have found is that more stimulation is not better. We need to be careful to gently offer the stimulus, wait to allow the baby time to respond, and that means no wiggling, twisting, or pushing the nipple. This is also one of the few times in my practice that I will try a little bit of light chin and cheek support, because sometimes helping the baby to close the mouth around the stimuli can help them to form a meaningful latch. Once the latch is achieved, then I'm taking that support away because I don't want to bombard the baby with too much sensory input, but it can be a helpful technique to use just with achieving that initial latch, just with a baby who is actively engaged and looking for something to suck on, but unable to localize it. So very different than using chin or cheek support for a baby who is asleep or disengaged, as that would not be recommended. So for breastfeeding with these babies, sometimes a nipple shield can be really helpful. So just as they have trouble latching on a stimuli in their mouth, you can see the same thing with the breast. And the reason for that is they may need a little bit more sensory input to the mouth, and a nipple shield can provide that. So finally, we want to make sure that we are supporting the baby with flow control. So with breastfeeding, that might mean starting the baby on a pumped breast if they're having trouble latching or feeding from a non-pumped breast. With the bottle, that might mean external pacing, but we're offering this for a different reason than our premature infants need. So with our infants born prematurely, we're offering external pacing because of their decoupling of suck, swallow, breathe, and the feeding-induced apnea that they have. With our neonates with HIE, it's less often that we see that, and more often that we have a baby that has trouble with the initial latch, but then once they are latched, almost kicks into a perseverative feeding pattern where they are feeding at such a fast rate that they're not going to be able to keep up from a coordination and safety perspective. But because it can be so hard for them to form the latch, we don't want to pull the bottle out and have them restart that process. So teaching parents how to externally pace the baby allows the baby to keep the latch, but slows the flow of milk enough so the baby can safely feed. And then finally, we do want to be assessing what is the most appropriate nipple and bottle choice for these babies in case they do need a slower flow. Perhaps one of the most important tasks of a newborn's life that we can support as neonatal therapists or clinicians is breastfeeding. So this is a very recent study from Kruger and Associates that looked at breastfeeding behaviors of 28 neonates with HIE and 30 controls. So the infants were assessed with the preterm infant breastfeeding behavior scale, and very significantly, 89.2% of the neonates with HIE had at least one symptom of oropharyngeal dysphagia. That is just incredible. That means that almost all of them had some sign that they were not swallowing well. Additionally, the babies with HIE also had less obvious rooting, a shallower latch, and more single sucks. So the babies with HIE had the most difficulty with some of the following things listed on this slide here. So as you can see with arousal, about 71% of them fell asleep after 4 to 5 minutes. So again, they did not have either the endurance or state control to last for very long with the feedings. And additionally, there was quite a bit more irritability with these patient population. Only about 18% were able to maintain that quiet alert state. More often, the babies were frequently fussy or infrequently fussy, but that fussiness was still there. Abnormal tone was noted in 88% of the population. And then in the category on the right, you can see that there was increased oral secretions in over half the group, coughing with about a quarter of the population, noisy breathing, gurgly vocal quality, nasal flaring, fussing behavior, lots of other difficulties that we're seeing more often with the neonates with HIE. So what was the takeaway from the study? Given the difficulties and safety risks noted, the researchers recommended that early introduction of oral feedings should be well timed to minimize risks. Additionally, they advocated for early assessment and involvement from feeding specialists. So feeding specialists can help to improve the safety of early breastfeeding, as well as maximize and support breastfeeding outcomes. And then finally, the research also recommended that breastfeeding support should be standard for all of these patients. So of course, if we do not have improving oral feeding success, or there are continued safety concerns, there are ways to evaluate further by our instrumental evaluations of swallowing. So a video fluoroscopic swallow study is completed in radiology and looks at the baby's swallow under fluoroscopy to get an idea of where everything is going when the baby swallows. The other instrumental option we have is fiber optic endoscopic evaluation of swallowing, where either the ENT or SLP places the endoscope through the patient's nair to look at the pharyngeal swallow from above. But knowing the issues with irritability, poor state control, and difficulty latch The differences between these two studies need to be very carefully considered, and the patient's individual skill set and ability needs to be considered before recommending one study over the other. Depending on the results of the study, there are some adaptations to improve safety, such as having the mom breastfeed after pumping, limiting the volume or frequency of feedings to minimize the risk for aspiration, use of thickeners, which generally is used as a last resort. So although thickeners change the viscosity of the liquid and often improve the safety of the swallow, there are a lot of implications about using thickeners with the immature gut of a neonate. So it's something that should be used with caution and only under clear direction from your medical team. And then a newer adaptation to improve the safety of swallow came from a study by Luisa Ferreira, who's an SLP out of the Northeast. And what she did was video fluoroscopic swallow studies with infants with identified dysphagia on room temperature and then also cold liquids. And what she found was when colder liquids were used, deep penetration and aspiration both significantly decreased. So her study was a pilot study, but I'm really curious. I'm looking forward to seeing the next round of results as her work continues. So there is also some newer research to improve swallowing performance by neuromuscular electrical stimulation. And this was a recent study from Sick Kids in Toronto. And they looked at infants and children with neurologic impairments from 0 to 24 months. All children in the study had severe swallowing issues per video fluoroscopic swallow study. And the treatment that they received was the neuromuscular electrical stimulation by a trained OT, 20 to 45 minutes twice weekly for 24 months. But amazingly, 100% in the treatment group demonstrated improved swallow by VFSS. So before the study was completed, 5 of the 7 patients in the study were initially fed completely by a tube. But after treatment, all 7 were able to do at least some oral feedings post-treatment, which I think is just incredible. And 3 actually established full oral feedings. And because oral feedings are so important for babies' future development, and also it's an important activity for their parents to do with them, I think it's also really significant to note that the researchers found that 5 of the 7 caregivers felt that feeding was improved and were really satisfied or pleased with the intervention. So I know I'm preaching to the choir when I state that early involvement of neonatal therapists is a wonderful developmental support that should be offered, because neonatal therapists can help to provide recommendations for a safe oral feeding plan, neurodevelopmental assessment and intervention, as well as family and caregiver education and advocacy. But while this study focused on neonatal therapists, it really should go without saying that there's an incredible value in having trained neonatal clinicians such as nurses, especially when we're working with these babies who are neurologically impacted. It is really important that any clinicians working with these patients understand the rationale and reasons why certain developmental care is needed, as opposed to the needs of preterm infants, which is a very different patient population. Although it should be clear to everyone on this webinar how important having specifically trained neonatal clinicians is, in reviewing the literature, I found a study that wasn't quite so confident in that. And this study evaluated centers that offered therapeutic hypothermia, and it assessed what services were provided, and more importantly, it looked at what services providers thought should be provided. So for instance, on the left-hand side, you can see that the facilities were mostly in agreement that nursing staff should be trained in therapeutic hypothermia before a facility should offer it. So 83% felt that it was critical, and 15% felt that this was recommended. Access to developmental follow-up, the facilities were almost in 100% agreement. It came to 98.1% that access to developmental follow-up was critical. However, if you look at the bottom right of this slide, and when the researchers ask these centers, should occupational and physical therapy be required to consult? And 72% felt it was critical, 22% felt it was recommended, and about 4% thought that this was optional. So as neonatal clinicians, I think it is a huge part of our role to advocate for this. And so that could mean sharing about services you are already provided, or providing education about services you can provide so that your services can be included as standard for these babies. So now that we talked about some of the beneficial interventions for these babies while inpatient, let's return to the research study for a moment. How were these babies doing by therapy discharge sessions? And I'm happy to report that there were some really vast improvements, and the Rubik's Cube is starting to come together. So before we go over the results, I'm going to give a little orientation to this slide. So on the y-axis, you see numbers there. Those are not percentages. Those are the numbers of patients that had each particular thing noted in either their evaluation or discharge. The dark purple indicates that the particular symptom listed was noted during the therapy evaluation, and the lighter purple means that it was still noted by discharge. So right away, you can see how many patients had difficulties that really started to dramatically improve by discharge. So for state control, about 2/3 of patients had issues with this at the therapy evaluation, but it decreased to less than 20% by the time the babies left the hospital. Abnormal tone was noted in about 80% of the babies initially with their evaluations, and that dropped off dramatically to about 30% by the time they went home. About 2/3 had that difficulty with latch that we've talked about so much, but by the time they went home, less than 7%, which I think is incredibly dramatic. Now for our safety concerns with feedings, while 1/3 had coughing, choking, or upper airway congestion with feeding, that number dropped to less than 10% by discharge. So it's really amazing to see what progress happened from the initial evaluations to discharge. So the findings from our study correlated really nicely to what is already in the literature, such as this study by Murray. So what Murray learned was that the best predictors of long-term developmental success most closely correlated to neurologic assessment at day of life 3 and the neurologic examination at discharge, which was the strongest correlator to future developmental success. So important findings from this: persistently abnormal neurologic exams correlate with adverse outcomes. So we know if an exam is consistently concerning, that likely means there may be issues in the future. But also really, really important, later neurologic exams have stronger predictive abilities. So my point in sharing this study now is really to highlight that these early neurologic evaluations often change. And sometimes the most accurate findings are the ones later in the hospital stay or near discharge. So to return to this graph for just a minute, I think it's incredibly important to note how these babies changed and improved from the therapy evaluation to their discharge. And for this reason, it's really worth keeping in mind how these infants may evolve or change. Prognostication and even anticipation of the need for outpatient therapies or the decision about an instrumental evaluation of swallowing from the initial eval will not correlate as strongly to long-term outcomes as our discharge evaluations. So often, these babies need time and they need our support. So what were some of the other findings from this study by discharge? Well, in examining how these babies were to be fed at home, I'm pleased to share that of the 72 babies, 3 discharged home with gastrostomy tubes and 4 discharged home with NG tubes. So the remainder either went home on full oral feedings or transferred to an outside hospital closer to home, so we don't have that information. But again, only 7 babies needed some amount of enteral feeding support at discharge. In regards to the bottle and nipple that was used in the discharge note, many of them did unfortunately go home with their last feeding being done with the hospital grade nipple. And so with this feedback, we have worked to improve on having families bring in home bottles more often to ensure that bottle is going to be safe and appropriate for the baby before they go home. We did have a small cohort that needed a very slow flow nipple. So obviously the majority went home on a regular slow flow, but some needed a preemie flow nipple as well. For our study of 72 patients over a 4-year span, only 4 received a video fluoroscopic swallow study, which I have to admit was a lower incidence than I thought may have been the case. Of the 4 that did get a swallow study, 3 had identified swallowing issues. So again, I must stress that if the baby appears adequately safe and is continuing to improve, it's really important to wait on these studies. Of course, ultimately, if you do have a baby who is consistently demonstrating safety concerns while feeding with no improvement, further evaluation can and should be completed. Another interesting find, at the time of the study, we had no infants who needed to discharge home on thickeners. So it's important to note that the cohort for the study was from 2013 to 2017, which is very close to when the FDA issued their warning about thickeners, which was in 2012. So that probably impacted the number of patients we had go home on thickeners, because again, it was none. But since the data collection formally ended, I honestly can only think of a small handful of babies with HIE who have needed thickeners to feed safely for home. So what is the significance of the results about feeding? First of all, there is a known correlation between developmental outcomes and feeding progress, and I think that that holds up for this patient population. So this study on neonates with HIE who experienced therapeutic hypothermia for treatment looked at the clinical evaluations on day of life 10 to see what had the strongest correlation to the abnormal MRI. So at day of life 10, these research looked at the oral feeding ability, the baby's activity, mechanical ventilation status, and a history of seizures. And the strongest correlator to an abnormal MRI was continued feeding difficulties at day of life 10, as well as any type of seizure activity. So the researcher said with confidence that infants without seizures who attain full oral feeding by 1 week are unlikely to have an abnormal brain MRI. For our study, for outpatient therapy referrals, approximately 25% of our cohort was referred to physical therapy, and about 30% was referred to occupational therapy. And again, a small percentage went to other hospitals before they went home, so we don't know what was recommended. The reasons for outpatient physical therapy were abnormal tone, asymmetries, head turn preference, and poor state control. The reasons for referral to outpatient occupational therapy were a discharge home on any type of enteral feeding support, but also babies who went home on full oral feedings but maybe had marginal intake, struggles with weight gain, continued latch difficulties, or even mild swallowing concerns that were improving. And also babies with state control issues, because we know that that can impact how a baby successfully feeds. So pretty much all of these babies should at least qualify for the NICU discharge or high-risk infant follow-up clinic, if not early intervention as well. In California, there have been some inconsistencies with counties accepting these babies for early intervention. So what we have discovered is that some centers do not consider HIE to be an automatic qualifying criteria anymore because therapeutic hypothermia has helped to improve their outcomes. So we've had to get a little more creative to get babies plugged into services, such as looking at a history of seizures, length of time required on a ventilator, APGARs at birth. So I encourage you to really dig deep in the chart when making these referrals so that babies can get plugged into services. So what happened as a result of this study? Probably one of the most important things is we actually now have changed order sets that automatically include physical therapy and then also feeding therapy for all of these babies. What used to happen is we would see these babies if a problem arose. And so sometimes that meant we were running to the unit to see a baby as they were packing up and getting ready to head home because the baby was coughing and choking or parents had questions with feedings. And hopefully everyone on this call knows that that is not a very effective way for therapy intervention. So now we automatically get referrals and are involved with these patients very early on. Another thing that I feel was a positive from the study was being able to disseminate these findings with you guys today. My participation in the study also opened the door for future studies. And at our facility, I feel like it reinforced that bedside clinicians can be researchers too. So I don't have a PhD, I don't have a strong research background, but I have a strong interest and I'm willing to take on the time to do this. So I hope that this inspires some of you to think of things you may want to research in the future as well. Now that the cohort for our study is all at least 2 years old, our next direction is to correlate some of the early findings with longer-term follow-up, such as the developmental outcomes from our high-risk infant follow-up clinic, the long-term oral feeding status. Are these kids continuing to feed well? Are they hanging on to their growth curve, or is failure to thrive something that is coming up? And then also, what is their head circumference, as we know that that so closely can be a link to development. So there are some future directions in research in this area in general, one of which is looking at preemie cooling. So trying cooling with infants younger than 36 weeks. So I know there are research trials out there looking at gestational age 33 to 35 weeks. Also, there are studies emerging about mild HIE and cooling, as current protocols are for moderate to severe HIE only. Optimizing cooling continues to be looked at as well. So looking at longer and deeper cooling protocols. So right now the standard is 72 hours, but what happens to babies' outcomes if they're cooled longer for 120 hours? What if the temperature is decreased from 33.5 degrees Celsius to 32 degrees Celsius? How does that impact the babies? And then one of the studies I'm very excited about is the HEAL study, which is a larger scale randomized control trial that looks at high dose erythropoietin for asphyxia and encephalopathy. So EPO stimulates red blood cell growth and has been found to be neuroprotective in TBI, Parkinson's disease, and depression. So what can EPO and cooling do together for babies with hypoxic-ischemic encephalopathy? And then, of course, the thing that I'm always excited to see is what is going to be the next rehabilitation or nursing-driven study. So one of the questions I have often received after completing this study is, how did you do this as a bedside clinician? And logistically speaking, it was a lot of work, primarily outside of my regular working hours. And it really started with a deep dive into the literature, some of which I shared with you today. I did complete some additional training, such as the Collaborative Institutional Training Initiative and the Orientation to Conducting Clinical Research. But I have to say that most importantly, the reason this was able to happen, and I feel incredibly grateful to this, is the NeurNICU research team members. So I had a team where I work that was incredibly supportive and excited to collaborate. So Dr. Van Meers and Dr. Bonifacio were really critical. And then also Dr. Iris Morag, which is a neonatologist from Israel who was here working on some other projects and happens to have a passion for feeding and developmental outcomes of babies. And so she and I worked incredibly closely together for long hours to really get this done. And of course, I'm really grateful to the neonatal therapists and other clinicians in our NICU that provided such excellent care and support for all the babies in the study. Here are my references for your review. In closing, I just want to say again how excited I was to have been asked to share my own research with you all. However, in sharing my study, as well as some of the other research that is out there, I hope you've come up with some additional ideas of things that need to be researched now, especially so far as therapeutic strategies and outcomes from a therapy perspective. There are certainly holes in the literature, so I'm going to end this presentation with a shameless plug for the need for ongoing research from neonatal clinicians, and that includes therapists, nurses, and other team members. I would love to hear of another upcoming webinar or read another study about rehab or nursing-driven initiatives to help this very special population of infants. My email address is on the slide, and I'm very happy to help support you in any way I can and answer further questions. Thank you again so much for taking the time to come today.
And you all have places to go. I wanted to try and just get 1 or 2 questions in real quick. For the questions that are not answered, they will be posted on our website when we post the webinar. Kelly, can you hear me?
Yes, I can.
Okay, great. All right, here's a quick question. Can I ask you what technique you use to not have to remove the nipple but still offer external pacing?
Yeah, that's a really good question. As we talked about in the presentation, because moving the nipple and also the difficulty establishing latch with these babies can be very difficult. We want to try to keep that latch intact. And so often that might mean moving the bottle just enough to take the milk out of the nipple, or maybe it's moving the baby and the bottle together so that that latch stays perfect, but the milk comes out of the nipple. So there's a couple different things that you can try and see how the baby tolerates each strategy.
Okay, great. Thank you. A lot of people are still on, so I'm going to answer these questions. Are there any contraindications with the neuromuscular stimulation? Is it contraindicated for children who are known to have seizures?
That's an excellent question, and the NMES is being looked at for younger children with HIE and neurologic issues is a relatively newer thing. It's something that has been around for a while, but really focusing. This new study just came out in 2019, and so I would actually recommend looking through the Marcus study in a little more detail. I don't specifically remember that contraindication, but I would reference you to that study to make sure that you're following the protocol that they recommended.
Okay, great. And then people want to know what neurological exam was being used. There's several questions about that.
What neurologic exam was being used in the study?
Yes, I believe so.
Oh, yeah. So there unfortunately was not a standardized assessment. And if I were to redo this study, especially as a study moving forward, this was a retrospective study. So there was not a specific standardized assessment that was used. And so the information was pulled from the therapy evaluations only.
Okay. And then because we mentioned the NMES, let's just follow up. There's one more question. Was the study relating to it up to 24 months rule out factors like maturation?
That's a good question, and I'm not sure. I believe because they were looking at patients up to 24 months, I would assume some of them were kind of at their assumed neurologic baseline. So I think it might be hard to tease out if it was maturation that improved the swallowing or if it was the intervention. But again, I would reference the Marcus study itself and recommend taking a look at that.
Okay. Great, thank you. I know we're out of time. We went over anything that didn't get answered or that questions continue to come in, we will post on our website. And as we wrap up this presentation, Dr. Brown's Medical would like to thank Kelly as well as all of our attendees. Our next webinar is in February and we'll tackle dysphagia management in the PICU. So keep on the lookout for our registration page for this highly anticipated webinar. Have a great day, everyone.